fields. We are now recognize them. It's an established approach to improvise what we practice. Colorectal surgery, orthopedic surgery, gynecological surgery, cardiac surgery, name it, urology. Bariatric surgery, and many of us here, I would be very familiar, just like others. Patient education has become so important in bariatric surgery. For its success, nutritional support has become almost center stage. Multimodal analgesia, follow-up care, standardize and optimize the surgical experience, talking to colleagues, their experience, collating and attending meetings, and then putting data together as to find out the best answer. An emerging field, any emerging field should have gone through how bariatrics has gone through, what changes have taken place. We thought it's a straightforward procedure till we started doing it and we realized, well, there was so much which unearthed, and then it was steered, navigated to the right direction, and it will continue to evolve. Pediatric surgery also have spent 40 years in pediatric surgery as a trainee and one of the best institutions in the country, and then culminating into research and as dean. Now our babies, we see now antenatally, fetuses. You can make a diagnosis there. We follow them postnatally, lifelong almost. Our patients don't stop at 18. They keep coming to us. And now I'm regularly attending the marriages of the patients which I have operated. I have so many photographs. Very happy. Wide age group. We see newborn, we see older children, and we follow them up. As I said earlier, we see different shades of the natural history. Not all children come at newborn. They come depart because of the different socioeconomic background. Sometimes they come late and see the natural history in its worst forms, which should have come much earlier. And we have opportunity to course correct. We follow techniques. We have opportunity to follow up those patients, those techniques, and see, well, this was not the best way to do it. There should have been better results. We modify the techniques. That's course correction. So I'll talk about two broad pillars, and just because of the time constraint and obviously, CACUT, one, congenital anomalies of the kidneys and urinary tract, which is eminently diagnosed antenatally today. These are structural malformation and we are able to follow them up during the antenatal period, then postnatally, and there are many queries. Then I mentioned about course correction. There are many conditions, penile deficiency states, synostosis, and a pediatric surgeon actually does from top head to toe. All the surgeries, even today, gradually there has been a development of subspecialties, but in our country, there are so few pediatric surgeons. We have to do most of the thing, aplasia cutis cerebri, minimizing tissue injury, optimizing existing procedures, reducing complications. I'll give you examples of some of these, not all, because of time constraint. Now, talking about CACUT, pelvic-ureteric junction obstruction can be diagnosed antenatally. The last 30 years have been plagued with the query when to operate upon them, because once you diagnose them antenatally, by the end of the third trimester, half of them disappear. The hydronephrosis is gone. The rest of them will start disappearing postnatally. So gone are the days when we used to diagnose them when they presented with pain, fever, pyuria. Now the newborn is asymptomatic. His mother has been told antenatally that your baby has a problem. Imagine the entire pregnancy has been a burden. Postnatally, she comes and tells, my baby is all right, sir. What have you told us? But here is a pathology which may require surgery, may not require surgery. The tools we apply to make a diagnosis fail because sometimes it opens up on its own, because it was opening up antenatally also. So how to pick up, when to tell that this is a patient who is a surgical case, this is a baby who will be all right after some time. So we sometimes have very procrastinated follow-ups. If you look at it, this curve, which should have gone up, this is an obstruction. If it has gone down, it is not obstruction. It goes like this, equivocal, and it may take any trajectory during the follow-up. And therefore, we have to keep following them up. Does waiting risk injury? If we are following up a child, he may come back in the next follow-up with damaged kidneys. Is there a discriminatory? क्या अपने आप ही हो रहा है? I'll leave it here. Oh, shall I have to keep it like this? There's something which somebody has to help. So as you stood, it became all right. So I'm sorry that I have to ask you standing. Does waiting risk renal injury? Is there a discriminatory factor which can tell you upfront, here is a baby who's a surgical case, and here is a baby who would not require surgery? There was no such marker. Why function does not always recover after surgery? We can see a baby, we call it a surgical case, we operate, we expect function to improve. That's why the surgery was carried out. It doesn't. Now, what we started doing was that we looked at why damage takes place. The damage takes place, if you look at this chart, this is the well-known pathway for the cardiologist and for all of us now. In fact, every organ has now RAS integrated into it. So this pathway, you see apoptosis at the end. That's what the damage is like. And we thought that if kids during follow-up become surgical cases or the injury starts appearing, something might be happening at birth also. This pathway, which causes damage, must be activated. So I looked at this pathway. We looked at up into the pathway and we looked at the primary player, which is plasma renin activity at the glomerulus. And we thought that if this kid who has got hydronephrosis is not an indication for surgery, and if he is destined to become a surgical case, his renin should have been raised now. So we kept on following them up as one would follow, but did a post hoc analysis. We kept renin as a data to be seen later on as a post hoc analysis. And we realized that yes, those patients who were destined to become surgical cases, they had very high levels of renin right in the beginning. And once you operate upon them, the renin falls down. So they were high right in the beginning, but they were not operated that far. They were just kept on observation. Therefore, renin then became an indicator at a point of care test, which we have published recently in Journal of Nephrology, as an indication for surgical intervention. So this is a story that when we talk about a pathology which is diagnosed antenatally and we do not sure how to operate, we can have these data and they can put up. We even drew a Kaplan. Those who were not operated continue to have rising levels. Those who were operated had a fall. So obviously renin was the marker. We published it in Journal of Urology way back in 2007. And after that, there were many studies in Hopkins. We also drew in about more than 300 cases a Kaplan-Meier curve comparing split renal function with glomerular filtration rate and with renin. And we found that the attrition, if you take renin, most of the patient could be operated if the renin is high alone. And those who would be followed up with all other will continue to be followed up forever and have damage. So these are the data, and I've just told you that this is the clinical problem at hand 30 years ago, and over a period of time, we were able to find a solution. So now that we had something to be confident about in terms of the babies that we follow throughout our lives, we started looking at situations like posterior valve, another CACUT condition. 44% of the kids of PUV go into CKD by second decade of life, and this is not changing. This is the figure when I read Kalalis and King as a resident, and this figure is same even today, after 40 years. So obviously, there are shades of spectrum, especially when you can diagnose these conditions antenatally. Why now that the prognosis not improve? We were diagnosing them late. They were having damage CKD. Now we can pick up them antenatally. Why still the CKD is so high? With that question, we applied the same tool. We looked at babies who become all right. There are patients other than 44% who do well. How do you identify those who would be 44% and those who will be all right? So we wanted to look at marker because those who are destined to have damage, we can identify and monitor them very closely. This group would be a very hardcore group to be followed. And can we do some intervention into them was the question. So we looked at this group. We found that renin remained normal in those who were beyond those 44%, the low risk group. Once you do valve ablation, the renin falls down until the last follow-up in this study was 2 years after birth, after valve ablation, it remained normal. There was another group in which renin fell down for a period of time, started rising again. So we thought, again, and historically, that we have ablated the valve, everything will be all right, forgetting that very soon they will go into damage. They contribute to that 44% of the pool. Another group was in which renin never fell down to normal. It plateaued at a very high level. So this means that those intrinsic tubulointerstitial compartment where the changes are happening, it continues. The kidneys get, you can say, vaguely programmed into injury. And therefore, this is the group which actually goes into that 44% high failure rate. So if there is a pathway, you can block the pathway also. So I thought that if you can pick up a pathway, the advantage only would be that if you curtail it. So we blocked the pathway by ACE inhibitors. And we found that the function improved. We published this data. I have curtailed some slides, Journal of Pediatric Urology, 2008, that if you cut the pathway in this high risk group, you can actually retard the pace of injury. Function will gradually start improving. And you look at these babies have about 90 years of life. If you can do it early, you can. Then we again looked at urinary markers so that it becomes less invasive investigation. We again curtailed the pathway, and we found that these pathways did be controlled, and we published in pediatric nephrology. In fact, started giving thesis to residents, and it was published at most places. So, what I want to say is that a clinical problem, which as surgeons we deal, we see our babies, we treat them, we see them and follow up, and we see them going down in kidney function, is what propelled us to do some research and see what can be done. We can make a diagnosis of posturacial valve now antenatally. We can do an intervention. The outcomes are not very good because by the time we do intervention, the injury has already taken place in the kidneys. But with time, I'm sure there will be better answers. Now, third thing in CACOT is important is vesicoureteric reflux. The question here is, should we continue reflux on medical treatment, antibiotic prophylaxis, or we stop the reflux, which means should we treat reflux or cure reflux? If we stop reflux, we have cured it. If we keep treating infections, we are treating it. To prove this point, we looked again up to a very encouraging marker, the renin-angiotensin system and the plasma renin activity. We all know that if you look at this damage, then reflux leads to stasis, pyelonephritis, scarring, decreased function, and decreased somatic growth. Therefore, if urine is kept sterile, which is the proponents of the medical treatment, they say that urine is kept sterile, it should be all right. But there is continued reports of pyelonephritis despite prophylaxis. There are many papers, many trials have proved that prophylaxis does not prevent pyelonephritis, which means they would not prevent CKD. And this occurs because there is a water hammer effect. Every time the bladder empties, reflux leads to a water hammer effect. As we all know, the pressures are transmitted. And what happens there, I wrote that this juxtaglomerular apparatus gets hemostatic disturbances. It releases renin, and that causes damage. So therefore, if you are following up children with vesicoureteric reflux, measure the renin. If it is high, this is the case where reflux should be stopped. I published this first in 2003 in Kidney International. It's a very hardcore pediatric nephrology journal, very difficult journal. And I failed to find another surgeon writing and publishing it there. I received an excellent comment by the then a very senior 85-year-old editor, a gentleman Jew, I am forgetting the name, and he wrote to me that this is a path-breaking work, continue this. So these are encouraging words. So he was not my teacher, but this is how we as editors, Dr. Leena was mentioning that she is coming out of the journal. These are the encouraging things we at our age and stage should be able to do. Encourage people who write good papers so that more and more come. So I'm showing these data, which very clearly shows in Kidney International, then subsequently in Journal of Pediatric Urology, and many more after that. Many of my students keep writing now. You can see that with surgery, renin falls down. It becomes an indication. Now we have deflux available. It's an easy thing. And this can be deposited very nicely. It's a 2-minute job. I did a case just in this morning, and it stops reflux with the same results as open surgery. You can see that there's a fall in macroalbumin, there's a fall in renin activity. So macro-invasive or a minimally invasive surgery is also as good. Now I'll come to the surgical part. This was the research part on antenatally diagnosed CACUT cases. We needed very fine sort of observations there. It required bench research. We created a laboratory in my department. That room is still having the laboratory, 4005. Now, looking at when we as surgeons, most of us, can we do some course correction to the things that we do? We should not change our techniques just for the sake of it. We should do it if there is a clear indication. And we are not getting good results with anticipated ones. So I'm just taking one or two conditions only because of the time constraint. So as pediatric surgeon, I feel that I'm like a scuba diver, which goes in deep sea, and deeper you go, you see different kind of fishes, monster fish, surgeon fish, etc. Similarly, we see kids with different anomalies. It is sad to say this, but we are here to correct them also. A kid with bifid tongue, a child with no tongue at all. See the extremes that a pediatric surgeon has to go through. Child with double phallus, no phallus. See the devastating family. We have seen that. A child with 3/4 of the scalp missing. Dura was exposed. You can see the thrombus on the top of the superior sagittal sinus. And then you see child with premature ossification, right? And this should have happened at 35 years postnatally. This happened antenatally. The bones are fused in different permutation. Now, I'll tell you 2 or 3 examples. So this kid, for that matter, we were able to offer him a surgical technique which was very simple. We all know scrotal has a huge, good supply, very exuberant supply. We raised simple flaps. If some of the very senior Dr. Tyagi is not here, but there is nobody of the stage of seniority except Dr. Mishra is here. You can identify the Waterman bottles, the broad-based bottle with a very small neck. So that gave me the idea. And I raised this flap on the scrotum, took it up, fused it together or joined it together, and created a small phallus. In a 6-month-old baby who doesn't have a phallus, in our country, kids go around naked in the villages. One question is asked, boy or girl? And what does the parent say if this is the scenario? But now they have something to say. I could remember the crying mother with happiness when she saw the baby. So these are things, but this was not enough because this would not grow. But it was only enough to tide over a period of time. So this child came, which we had operated for hypospadias, disorders of sex development, but penile growth is not very good. He came at 17 years of age. He had selected an engineering college in Lucknow. The family came crying that he doesn't want to go back because he has got what we all know now, the locker room syndrome. They just don't want to be there. And therefore, they said, do something about it. So when I looked at the procedures available for phalloplasty, I found they were really very, sorry to say, ghastly. You can take thigh, take part of the fibula, and do macrovascular anastomosis, tube within the tube, great scars, bones, fibula will not stay, it gets resorbed, muscle flaps atrophy because they are not functioning. So when I reviewed in 2006 review of the articles of various procedures, the results were very dismal. I didn't want to do something which would fail. Didn't want as a teacher to train my students in taking up a procedure which would have high failure rate. Rather do something which all of them can easily do with their training. So I decided to do what is called as a bird wing, flying bird wing abdominal flaps. If you look at this flying bird, so I created this flap with its base at the suprapubic area. This broad base was able to sustain both the flaps. You need a base, and the ratio between the base and the length, this was enough for both, and the superficial circumflex artery was able to sustain both the flaps. I then rolled it like this. I remember a trainee from Bahrain was visiting us, and she said, how do you call it? I had not named it then. I said Namaste flaps, because if you look at it, it was easy for me to find that, but I called it bird wing. It can be identified easily. Then you roll it up. You can see the scar was hardly visible. It's here, not in the front or thigh. It will just disappear because it's a linear scar only. And you can create, and we do it at adolescence because we need a lot of fat for it. And then we started doing regularly. This is the old method where he was taking the rectus flap with midline scarring, etc. But this flap is far, far better. And then we could do large flaps. This is the condition called bladder exstrophy. Again, a very, very defeating condition for the surgeons because these bladder can be rolled into a receptacle, but they don't grow. And it takes us 30 years to realize these will not grow. In the process, they are incontinent. In the process, we want to make them continent. We keep on doing bladder neck tightening, and the bladder which is not growing, and you tighten the bladder neck, you blow up the upper tracts. Very high rate of kidney failure. In another day, I'll talk about that part. But today, I'll tell you what we did. So I started doing very early on because I'd seen my teachers doing colon, ileum, etc., which had mucus flocculation, stone formation, infections. And thanks to those teachers, because of which I was able to think that keep me thinking something else. By that time, Leong in 1983 had come out with a gastric bladder flap. Michel had started doing it in adults and in children. And then I also started doing it. But soon we realized that any GIT segment confers a degree of malignancy to the native bladder. So there is a moratorium in USA now. You can't use stomach for augmentation for that matter. They forget that ileum and colon have the higher propensity, but not everybody can do gastrocystoplasty. Ileum and colon is far more easier. But nevertheless, we thought that we will remove the small bladder which is not contributing. Rather, we will create a gastric bladder. So this is the scar which is given when you do a gastric bladder. So I started doing laparoscopic harvesting. You put up 4 ports, and I'm not showing the video. It's an 8-minute video. I decided not to bring it here. It must be somewhere dug up, but some other day. But it's a good, elegant video because you can harvest just like what you do in bariatric surgery. Instead of removing that segment, I keep it on the pedicle. That pedicle and that gastric segment which Sandeep removes for the bariatric part, I keep it and take it down through the mesocolon into the pelvis and then replace the native bladder, which gave us very good results because that led to a sort of no chance of malignancy at all. So this is a big receptacle that you can create. Those were the open days. Now we are doing laparoscopically. I did one recently in one of the private hospitals also, a child who had come from Orissa. Similarly, now that esophageal replacement, the myth about esophageal replacement was that the longest part of the tube that you create for replacing esophagus was the summit of the fundus. That was the myth. And people were not able to take it for the high strictures, especially the ENT sees a lot of high strictures and they don't have answers for it. So I realized after doing so many gastrocystoplasties, I had probably more confident about the anatomy of the stomach. And I thought we can have a larger tube. It can go down here and even to the lesser curvature. When I did that, it was vascular. And we were able to give to many cases from ENT, from GI surgery. These kids are very tall, actually. I don't know why. We should do more study and research into why they become taller than their peers. And but that's how it is. They catch up with the nutrition. So this is a tube that you can create. This is a native stomach which starts growing up laterally later on. And this is the tube that you create. So these are the things. Today is the time of personalized medicine. I think Dr. Mishra mentioned about this. A time of artificial intelligence and machine learning. We now diagnose people not on the basis of the broad diagnosis of disease, but genetics, comorbidities, and lifestyle go into picture. They should be put in that AI model to make a diagnosis, and personal patient-specific treatment is being given, which alter and make better the surgical outcomes. National Board of Examination, I want to announce, we have started now. We'll roll down a 2-year fellowship for the doctors. Post MBBS, anybody would be qualified. PGs can also do. This fellowship will be with the Madras IIT. And for 5 months, 4.5 months, they would spend in the laboratories of IIT, learning Python and all other nitty-gritties of language. And the rest of the time, they will do in their clinical field. And so this will be there, and it will help huge number of specialties. Think about artificial kidney, artificial retina, the catheters that we use for cardiac catheterization. There's a huge, and inventories for the hospital administration. There's so much can be done if an MBBS is aware in hospital administration about AI and ML utilization. So that there are many uses, and so we would be rolling it down very soon. I thought this is an opportunity to tell you all. Thank you so much.
Thank you so much, sir, for the enlightening session. It was very much informative for everybody around here. Our next speaker is Dr. Pooja Sharma, CEO of Apar Health, who will be speaking on the topic research methodology. Dr. Sharma brings a wealth of experience in research and healthcare, and her insight are valuable and researchers for the clinicians and the researchers.
Thank you so much. Thank you, Dr. Agarwal, for this opportunity. Dr. Bajpayee has taken most of my thunder. There is very little left for me to really speak. So I'm going to actually start with exactly what thank you so much. So we're going to talk a little bit about why research. Sir has already covered that, its purpose, and how research is what I'm going to talk about. It's methods of research. So just to get the conversation going, how many of us remember our school mottos? So my school motto sort of stayed with me. It's called Truth is God. And maybe there was a Fauji here who might remember because this is from the army school. Okay. So yes. So the truth is God was a motto and it sort of stayed with me. Somewhere something's gone. From the school, I went on to my MD, and therefore I think, how important teachers are. And what sir emphasized is something that I would like to leave the teachers with, because I don't see any students today. But the teachers must take this message. How important research is can be emphasized only by a teacher. So let me tell you that when I started my MD in Gynae, मेरे को thesis में उन्होंने पूछा कि what would you like to work on? All I was doing in the labor room was episiotomy in the first year. So I said कुछ episiotomy में ही कर लेते हैं. So I told my guide very smartly, single layer repair versus multiple layer repair sounds like a good idea, simple to do. Let us do this. My guide said, what bunkum? This makes no sense. It's of no relevance. Nobody wants to listen to this kind of a thesis. Cervical cancer pe ho raha, abhi sab research. Tum human papilloma virus in cervical cancer. That's what you'll do. Okay. You don't argue with your guide. I'm sure all of us know that. Interestingly, so many people did publish on that, right? So people did work on that. It was not a foolish question, right? So that's one thing I want to leave with all teachers. There is no foolish question. And how did I come to that? Is because of Dr. Bhan. So when Dr. Bhan, I worked with Dr. M.K. Bhan for some time at AIIMS. And so I was a gynecologist, he's a pediatrician. So he used to make sure we would sit into all the journal club presentations. I used to say, sir, मुझे तो समझ भी नहीं आता pediatrics. आप साथ में बिठा देते हो, ऊपर से इतने discussion करते हैं लोग. I don't understand at all. Why are you making this, torturing me like this? Let me go do some real work. So he said, no, Pooja, if you're going to be part of a research team, you need to understand research. And how do you understand research? By sitting and listening to people. People talking about research gets to you at some point. So it's important to keep the conversation about research, to keep reading about research. So he used to say, everybody must read a paper every day, leave alone in 1 week. He would read 4 or 5 papers, I'm sure, in a week. So coming to the continuity of all my experiences, why research? To find the truth, coming from my dear army school background. To find the most generalizable truth that works within our group. So that is internal validity. The most extrapolatable truth, that means it works beyond my hospital in my group, is the external validity. So what is health research? Some kind of, why am I being... So health research, medical research or clinical research used interchangeably. The idea of research is to create evidence about human health, including disease understanding, finding better ways to prevent and treat disease. Now, we've all seen this diagram everywhere. This is the levels of evidence. But interestingly, this pyramid is changing, right? So this conversation that I really liked, this was in the BMJ, which said that the cohort, the case control, and the case reports, the systematic review is actually the lens. So we earlier used to think the systematic reviews are the top of things, but actually systematic review is just a lens looking at all the evidence that is really available. So again, I would like to emphasize to the teams here that everything doesn't need to be a randomized control trial. Sir started a lot of his research with the observational studies. It's a question of how critically we will observe the data that we are collecting every day. We collect a lot of data, we just don't look at it. I'm not going to talk about this. So observational studies are a highly undervalued, but actually really relevant work. In this, there is no intervention or manipulation of any variables. This is also called real-world evidence studies. If it's a cross-sectional study, it's like a photograph. Right now, what happened? If it's a cohort study, it's like a video. Can we see what happened to the kids? Sir has followed up children for 40 years plus. Case control studies in my life, I haven't seen, so I'm not going to talk too much about it. Interventional studies are the ones we think are the gold standard, which is the RCTs and assignment to drug treatment A, treatment B, which have their own values. Now, let me, because I like sort of over time have grown to like real world evidence. And so I would like to share with you a little WHO, right? This was a very nice WHO document talking about the health effects of non-sugar sweeteners. And therefore, when somebody asks me, what do you want Coke with? Do you want Diet Coke? My answer is no. I'm happy to drink the sugar. It's a small amount. So randomized control trials actually said that it decreases adiposity, decreases BMI, it sort of improves type 2 diabetes, has no data on all-cause mortality. But observational studies in real-world evidence actually says there's increased obesity, increased BMI, and a lot of diseases that increase. Now, why do you think that really could happen? I mean, if there were students, we would ask this question. Any students want to answer why this happens? Why in real world the data present, shows a different story than an RCT? Because in real world, we will eat made laddus out of the sweetener and not just 1 chammach of the sweetener, right? So real world is a very important story and all of us are participating every day in real world data collection. Can we start looking at our real world data? So this is a very interesting photograph. What do you guys see here? Anybody? Stars. Okay, so these are some stars. And what do you see here? A constellation. It's the Ursa Major or the Great Bear. What's the difference between this picture and this picture really? Is nothing. It's the same picture. What is the difference? The difference is, what is the question? So if you were just looking at the stars, this is what you're looking at. If you're looking to find the Great Bear or the Ursa Major, that is your question, right? So in research, in methodology, I'm not going to talk too much, but I really just want to leave you with what the most important part of research is, the research question. Am I right, sir? The research methods, everything will change depending on what your research question is. It defines your type of study. Will it be observational? Will it be a randomized study? What is its sample size? What are the parameters that you will study? What are the outcome indicators? And even the ethics of it are defined by this research question, right? All we really need to do as teachers is ensure that our students keep asking questions and learn how to critically ask a question, right? So first they have to keep asking questions, any questions, let them ask. बिकॉज वो ना पहले ही बोल दो क्वेश्चन बहुत गलत है, खराब है, बेकार है, तो बंदा बंद ही हो जाता है, क्वेश्चन पूछता ही नहीं उसके बाद. तो उसको क्वेश्चन पूछने दें, और जब वो क्वेश्चन पूछने शुरू करे तो उसके क्वेश्चन को क्रिटिकली एनालाइज करके पूछें कि इसमें आपको क्या चाहिए, इसमें आपको क्या चाहिए, एंड देन फिट इन. सो आई पिक्ड अप टू एग्जांपल्स. One is a surgical example and one is a medical example. Now, currently news article was around the SS mantra, so I picked up this one. Versus the Da Vinci. Okay, this is a simple question. We want to compare these two robots, robot versus robot story है. देखें क्या कर सकते हैं हम, research questions क्या हो सकते हैं, because our methodology will depend upon these research questions, right? So research question हो सकता है robot A robot B से safe है क्या, robot A robot B से better है क्या, surgery efficacious है क्या, effective है क्या, वो better है, as good as है, not worse than है. ये स्टडीज में हम कहते हैं सुपीरियोरिटी है, इक्विवेलेंस है, नॉन इंफीरियोरिटी है. इसमें क्या कंफाउंडर्स हो सकते हैं अगर हम ए और बी को कंपेयर करें? क्या सर्जन की स्किल इज अ इंपॉर्टेंट कंफाउंडर? क्या रिजल्ट इज नॉट बेस्ड ओनली ऑन द रोबोट बट ऑल्सो ऑन द सर्जन? इज इट ऑल्सो बेस्ड ऑन व्हाट द पेशेंट्स बैकग्राउंड एंड हिस्ट्री एंड यू नो हाउ डिफिकल्ट द सर्जरी इज? इसमें रैंडमाइज कंट्रोल ट्रायल करना चाहिए क्या? जबकि हम पढ़ते हैं रैंडमाइज कंट्रोल ट्रायल इज द टॉप ऑफ थिंग्स. What do you feel about a randomized control trial here? Now, how do we, when we thought of a research question, how are we going to actually think? There is this finer criteria, which I'm sure is nothing new for everybody sitting here. Whether it's feasible, interesting, novel, ethical, relevant. Now, possibly in AIMS, it might be feasible to compare these two because they have both the robots. But in any other institution, because they don't have both the robots, it's very difficult to actually compare the two, right? So what about if we plan this as an observational study? Does that make our study any lesser? Usse kuch matlab, is it a bad study if we just say ki let's observe our outcomes and we will present it? Well, in my case, I strongly believe real world evidence is a very strong study, provided we are able to put in some research methodological processes. And to this team, I don't need to describe those processes. So there are groups. And this is some time back. So today, if you're going to do laparoscopic surgery or open surgery versus robotic surgery, people might have a criticism because there are several robots available. But this is in 2016, they have actually compared a robotic surgery with the laparoscopic surgery. Coming to a medical example, NASH or NAFLD now it's called. Do diabetics with NAFLD do better on SGLT2 inhibitors for diabetic control? There is this, drugs that are being used in diabetics, whether these are actually working on the NAFLD also. Will it improve the diabetic control? Will it improve the fibrosis in the liver? Again, questions also whether it should be an observational study or an interventional study. The people who started as observational studies, so when the data starts, it almost always begins as an observation, right? And that's later an intervention can really be pulled in. Now, sir has given examples from his life story, and maybe I'll share Dr. Bhan's story with you a little bit, and I was lucky to play a small part in that. So he started with the rotavirus infection of children in his neonatal ICU, and he realized that these children who were getting these rotaviral infections tended to actually not get rotaviral diarrhea later, possibly as an observation, right? And then it led 10 years down the line to actually creation of a vaccine, which is currently part of the national program. So it's an observation of an ICU finding, which converted into a vaccine, which is saving so many people today. So it's small observations of things that you do every day that really can make a difference. Now, I don't think a presentation is complete without sharing something new, because बाकी तो सब वही है, finer picot तो मैं पहले भी बता चुकी हूँ, and I'm sure सबको यहाँ पे पता है. So let me tell you a little bit something new. New words that I have learned and I really love and enjoy is POEM, which is patient oriented evidence that matters. And this is not PRO or patient reported outcomes. This is patient oriented evidence that matters. Can we include the patient's voice while we define outcome indicators in our studies? Right? So it's important to listen to your patients, and especially if you have patients who are going to be with you for 40 years, you might as well listen to them, right? The other new word that I learned was OMOP and the common data model. So when I started clinical research, ICD-10 was the new buzzword, because we started coding diseases with ICD-10. Now the generation knows all about ICD-10. But interestingly, if you're doing an observational study in Manipal Hospital or in Apollo Hospital or in the US somewhere, or you're doing, creating a registry which is multiple centers, unless you are speaking the same language, we are not going to be able to collect the right data. So this is a very interesting new system called Odyssey, which is observational health data sciences and informatics vocabularies that work on a common data model concept. मतलब हम सब रजिस्ट्री बना सकते हैं, ग्रुप्स बना सकते हैं, डेटा इकट्ठा कर सकते हैं, पर हम कभी कंपेयर ही नहीं कर पाएंगे अगर हम लेफ्ट वी आर नॉट यूजिंग द सेम लैंग्वेज. So this uses the same languages. It's an interesting group. Like RedCap used to be in our days, free of cost. Odyssey is also a free of cost vocabulary. They keep conducting workshops once a month. Might be interesting to stop in and look at what they're doing. Take home messages that I request for all people here. Anybody can do research. Please, it's nothing that only neurosurgeons can do. Everybody can do. It's a lot of it is intuitive and a lot of it is common sense. The only real thing is पहले तो हिचको नहीं कि क्वेश्चन पूछना है, और क्वेश्चन पूछ के उस क्वेश्चन को threadbare डिस्कस करने की कैपेबिलिटी रखो. So let's talk defining the research question. That's a possibly talk in itself. Like in all other matters, ma'am, you said this, that how can we do research? I'm a very busy obstetrician, but you're not a solo busy obstetrician. You have a team. Similarly, make a team for yourself in research. They may not seem, they're a very low cost team. They're not, a resident might cost you 2 lakhs rupees per month, but these poor guys cost very little. Get them to collect the data, start analyzing the data, use your residents for doing during the thesis. You give them some interesting data to collect. Create that as a cohort in whether it is in your HIS itself or whether you want to use RedCap or any other such software. Collect information in systems. Do not collect information in Excel sheets. Right? Please collect information so that it can be carried to the next thesis. Right? Can we use those systems? So make a research team. Research teams start small. Even in the biggest of hospitals, research teams can start as small teams. Read, read, and read. This is the only thing that really will help you to write. So if you want to write, and I know my speaker after this is going to talk about writing, the only way to do it is read. Start small. Start with an observational study. Just make sure there is an interesting research question. It's an inquisitive team that you're working with. Somebody who's excited about research, right? Quality matters. Whether you are doing an observational or an interventional study, do a small study, but do it with immensely good quality, right? Ensure that you're collecting data well, right? All these are separate, probably presentations. We can have a conversation someday talking about quality of data in real world evidence. And it's not a difficult thing to do, right? So that's it from my side. Thank you so much.
Thank you so much, ma'am. And I believe everybody would agree it was a very inspiring, enthusiastic, and powerful discussion. I would like ma'am to be please here for the felicitation. And I would request Dr. Meenu to please come here and felicitate us.
Admiration for
Thank you, ma'am. Moving forward to the next interesting topic and the speaker. Our next speaker is Professor Dr. Rajiv Kumar, Professor of Urology at AIIMS, President of Society of International Urology, Editor of Indian Journal of Urology. Dr. Kumar will be speaking on writing a paper, a critical aspect of research publication. I welcome, sir.
Yeah, it's in that computer somewhere. Good evening. Thank you, Sandeep and Manipal, for this invitation. I could see Sandeep a little unhappy with the attendance, but Sandeep would remember we come from a age and an institution where we've often done classes for two people. And we're quite used to having our undergraduates. We don't have a compulsory attendance, and therefore we're quite used to doing classes with just two people and make sure those two never come again. Because it's only those two who will get all the attention. So we're quite okay. I'm going to keep this brief. I understand this isn't the group that needs to listen to this. They've all probably written tons of papers. So I'm just going to keep this brief. I'm going to cover the following few points, which is why do we write, which I think is the most important part. What we write and how we write is something most people here probably already know. I doubt there's anybody here who's written anything less than 20 papers. And more importantly, what not to write or what not to do is the only other thing I would cover. When we started writing, and this writing is not new, this started about 350 years ago, or probably even more than that, writing was done for altruism. Writing was done because it was the only way you were communicating your information to people around the world. When somebody discovered penicillin, the only way of letting people know was to put it all together in a journal and send it to people around the world. That's why writing used to be done. But the more important reason why writing needs to be done is because of something called the 1090 gap, which means 10% of the world's resources go into diseases which affect 90% of us. And on the other hand, 90% of the world's resources go into diseases which cover just 10% of the population. And therefore, if we don't do research on our own problems, nobody else is going to do it for us. You can keep doing research on the glorious or the glorified subjects, which nobody in India bothers about. So if you don't do research on diarrheal diseases and communicable diseases, nobody else is going to do it for you. But the more important reason why we write is not altruism. The more important reason why we write is because we write for ourselves. And that's a perfectly valid reason to write. Each one of us wishes to be the golden egg. When you're sitting in an audience of 500 people, you want to be the one who is recognized. And how do you get recognized? In the medical community, in the concept of science, in fact, anywhere in the world, there are only two ways of getting recognized. One is to make lots of money. That's one way of getting recognized. The other way of getting recognized is through peer recognition. And for people in the medical profession, that's called science, and that's publication. So these to me are the paths to success. The first path to success is the easy way, where you do webinars every weekend, you hold conferences every few days, you take out large paper advertisements, and you say, I am a celebrity. And obviously, if you say it loud enough, if you say it often enough, there are enough people who will believe you that you are indeed a celebrity. The second way of becoming a celebrity, and this is something which applies to most of us who consider ourselves in academic institutions, is to publish. And that's a more difficult way. Because for each one of us who wants to cross this path of publication, there's this bunch of people called peer reviewers or editors who are preventing you from publishing. However, to my mind, publishing, at least in the field of sciences or medicine, is a certain way of becoming successful. On the other hand, calling yourself a celebrity and expecting that that will lead you to publish a paper is unlikely to happen. So, although I'm speaking in a corporate environment, and this may not sound quite appropriate for the corporate environment, to me, in science, we don't blow our own trumpet. We are always taught to underplay ourselves. We let our work speak for ourselves. We do the writing, we do the research, we do the clinical work, and we don't go around announcing, I am big, I did this, and therefore I am great. That's the corporate philosophy. And if you travel around Delhi, there's a very interesting thing that's written behind auto rickshaws these days. All things written behind auto rickshaws and trucks are interesting. But one thing that I particularly find interesting is Prachar nahi to vyapar nahi. Brilliant. There can be nothing better to say that. Fortunately, we in the medical science don't have to do that. Therefore, you need to be the fellow on the left side. So that's about why should you write. The second question was, what should I write? Now, that's a more difficult question to answer. Again, if I look at it from the MBA philosophy or from the philosophy of marketing, the philosophy is you've got to have something to sell. The only way you will get yourself published in a journal of repute, not a journal that you and I start on our lookout next day. A journal worth reporting in is you have to have something to say. If you don't have anything to say, nobody's publishing you. So you need to have a USP. You need to have a hypothesis. You need to have a research question that's already been talked about. And you must be able to compile that information. And the second most important aspect of getting to publish is to be able to say it well. You have to be able to say it in as few words as possible. And this is quite contrary to what you've learned during your residency and during your thesis writing days. In your thesis writing days, you were told, make it as big as possible. The bigger it is, the lower the chance that somebody will read it, the higher the chance you will pass. When you're writing a paper, it's exactly the opposite. The smaller it is, the more likely that a reviewer and editor will actually read it, and the more likely that it will actually get published. Therefore, you need to learn how to write things smaller. And now go back to learning what you learned in school, précis writing. How to convert a 400-word article into a 40-word summary. How to write a big book chapter into a précis of 2 paragraphs. That's an art you need to learn. It's very easy to bring politicians on a stage, give them nothing to say, and they'll spend 45 minutes speaking about nothing. It's very difficult to bring an academician who has 45 minutes of work to put it in 10 minutes. That's what you need to learn. You need to be able to write it clearly. If you needed ChatGPT to write your sentence, I will need ChatGPT to understand what you've written. If you needed a dictionary or a thesaurus to find those difficult words to write, I will need a thesaurus or a dictionary to read it, and I don't have the time. As an editor, if I'm getting 10 manuscripts a day to review, the one that is more difficult to read is the first that goes into the bin. Make it simple. Everyday language, conversation. What is research? What is writing? Writing is conversation. Why are you sitting in this hall? That's a research question. I'll give you 4 sentences, and that's a research paper. People conduct conferences like this all across the country. We fail to understand why people attend such conferences, and therefore we decided to do a research on such conferences. We conducted a survey among all the attendees of a conference, a validated survey, to ask them why they attend the conference. We found out 5 people attended because they're Sandeep's friend. The other 5 attended because they'd been paid $5,000 to come to the conference. Therefore, we believe conferences should either be held because Sandeep is calling them, or they should be held if you're paying $5,000. Otherwise, you shouldn't be doing conferences. That's a research paper. And I'll show you how I've just done introduction, methods, results, and discussion. That's the whole paper. That's what research is, and that's what writing research is all about. It's not a big deal. If you're able to put your thoughts into a systematic order, your research is done and your writing is done. And I've just answered these 4 questions. These 4 questions were asked by a person called Sir Austin Bradford Hill. His greatest contribution to science was that he was able to show the link between smoking and lung cancer. But his most important contribution other than that was to give us the structure of a scientific paper, and that's called IMRAD, Introduction, Methods, Results, and Discussion. And I've just done that for you. I'll show you how I just did that for you. This picture is not there just because it looks nice. This picture is there because this writer is somebody who created this book. I don't know how many of you have heard about him. Atul Gawande is an endocrine surgeon at the Brigham and Women's Hospital in Boston. He wrote this book where he said, if you create checklists, you create fewer errors. And it's because of this book that we have the surgical safety checklist that the WHO uses. And why do I put it here? Because I use checklists. And IMRAD is a checklist which makes sure you put all the components of a paper so the reviewer or the editor doesn't throw it back at you. So what is IMRAD? What is the introduction? Introduction, you need to tell people why you did the research. I just showed you the IMRAD introduction of my small little paper. The introduction covers 3 questions. What is the known information? What is the gap in information? And what am I going to do about it? If you've answered these 3 questions, you've done the introduction. So the 3 questions I answered. Conferences are held all across the country. Known information. We don't know why people attend conferences. The unknown question. Therefore, I conducted a survey to find out why people attend conferences. Part 3, what am I going to do about it? 3 sentences, that's introduction. You answer 3 questions. This is the introduction written to one of the best written papers in the history of medical science. This is the Watson and Crick paper on DNA. The introduction is 2 sentences long. It covers all 3 components. We wish to suggest the structure of the salt of DNA. Known information, DNA. Unknown information, structure. This structure has novel features. Why am I doing? I'm defining it. 3 questions answered, introduction done, 2 sentences. The second part of your paper is what's called methods. Methods is what we call the Achilles heel of a paper. Again, that picture is not there because it looks nice. That picture is there because it sends a message. Those of you who recognize that fellow, good. Those of you who don't, he's called Brad Pitt. If you haven't seen the movie, go see the movie. The importance of seeing the movie is understanding who Achilles is. And the importance of understanding Achilles is to understand that one small part of your paper, that's your heel, is enough to destroy your paper. And that's because the methods is the most crucial part of your paper. You can write the best language. You can get the best author. If you haven't done the research, the paper is dead. The methods is what you need to put into your paper to tell people how this research was done. Again, this is the part which is the easiest to write actually, because this is the part that you wrote when you submitted your protocol for funding, you submitted your protocol for ethics approval. The method is already done. But if you didn't do it well at that time, you will never be able to write it well at the end. Again, I'm going to skip some of these parts and move on to the third component of the paper. The third component of the paper is the results. At the end of the survey, we found half the people came because they were Sandeep's friend and the other half came because they were paid $5,000. You need to answer the questions that you asked in your methodology. If you said, I'm going to ask 5 questions, I want to know complications, I want to know efficacy, I want to know costs, you must give answers to all the questions in the results. Typically, the results includes information that was not known when you started, and it's only information that you gathered through your research. You don't interpret. You don't say that, therefore, I believe Sandeep is a good conference organizer. That's discussion. Results is purely the findings. That's it. 10 people said they came because they're Sandeep's friend. 10 people said they came because they were paid $5,000. That's the only component of research. Therefore, I believe Sandeep should be holding conferences is discussion. So in the results, the most important part of being a part of the results is you must answer all the questions that you raised. Don't bring in new information. Don't bring in information to which you did not have methods. If you did not ask people about how they came, don't put in the results saying people came because they had a car. You never ask them how they came. So although you believe they're all rich people and come in their own cars, don't put that in your results because you never gathered that question from your research methodology. Finally comes the discussion. And this is the part where nobody knows how to write. This is probably the most difficult part of a paper to write. People know. Isme kya likho? The most common mistake people make when writing discussion is say, I found my study at 3% complications, his study at 2%, his study at 5%. Next paragraph, my paper, I found 4% patients right, his study found 2%, his study found 5%. Useless discussion. That's not a discussion. That's simply saying where your study is and where everybody's study is. When you write a discussion on a paper, The objective of telling is people should know, why should I bother? How does it matter whether your result is 4%? What is the value to me? It is of value to me if you tell me that this 4% matters, because I, who conducted a conference in a small hotel in Gurgaon, managed to gather 20 people, whereas other people who hold conferences in big halls can't gather that many people. It is the context and the result of that context that must be discussed. Don't just quote other people. You have to explain how a reader will benefit from knowing those results. So coming back to that 4% discussion, if you had 4% complication rates, you need to say, I have this 4% because I'm working in a small hospital, despite working with local help, despite having no water running in my hospital. Whatever be the reason that makes your result useful to a reader is what a discussion is. Otherwise, the discussion is useless. So don't just quote 10 other papers, give their results, and that's the end of the discussion. That's the most useless discussion that can be written. A discussion must make a reader understand, why was your result of any use? Why is this paper of any use? Again, that picture is not there to fill space. That picture is to convey a message. There is very rarely a study that is path breaking. Very rarely. Most studies are adding incremental information to an existing body of knowledge. And it is up to you to ensure that your discussion is balanced. Don't try to prove that I am the best, and therefore you quote all other papers which had poorer results. Nobody is perfect. Everybody makes mistakes, and the glass is always half full. The truth is that there is a glass which has half full of water. It's up to you to convey half full is good enough or half full is not good enough when you compare it with everybody else. Finally, the conclusion section. The conclusion section is always supposed to be based on just what you found. Don't extrapolate. Don't try to bring in assumptions. Like I said, that car assumption. We found X number of people came to the conference. All the people were well dressed. Therefore, we believe they all came in a car. That's maybe natural, but that's not what you did in your study. So don't extrapolate. The robot versus robot study. You're comparing outcomes of robot versus laparoscopy. You've got good results, but at the end of the thing, therefore, we believe laparoscopy is just as good as robotic and it is less expensive. It's intuitive to believe it's less expensive, but if you didn't do that as a part of your research, don't put it in the conclusions. I'm going to skip these parts because these are not a part of how to write. They were more about what not to write. So a summary on how to write a paper. It's very easy to write a paper if you've got your thoughts clear. Use a checklist. A paper needs to be planned like everything else that you plan in life. And remember, no matter how good your English, no matter how well you've written, no matter how much data you have, if your methodology is poor, your paper is dead on arrival. There are no shortcuts. ChatGPT isn't the solution. You put it into ChatGPT, you'll get an answer, you'll also get thrown out. And always be ready for revisions because most good journals will have an acceptance rate of 5%. If you get yourself accepted into a journal which has a 95% acceptance rate, the journal is pathetic. Don't get accepted there. Thank you very much once again for the invitation.
Thank you so much, sir. And I believe everybody would agree that it was quite an interesting presentation with a lot of functional examples. And thank you for pushing us to do this again. And thank you for pulling up our motivation for such sessions. But I would like to invite you back here for the felicitation part. And I would like to request Dr. Mishra and Dr. Leena and Sridhar to please felicitate, sir. Big round of applause for sir's presentation. That's it. Moving forward to our final keynote lecture, and one of the most important one: why do journals reject articles? We now invite Dr. Sandeep Agarwal, Chairman of Manipal Institute of Minimal Access, Pediatric and GI and Robotic Surgery at Manipal Hospital, Dwarka, also the editor of Journal of Minimal Access Surgery, to deliver his talk on why do journals reject article. This topic is key to improving the quality and success of research publications.
Presentation there. Yeah. Meanwhile, good evening, everyone, and first of all, a big thank you to all the dignitaries, Dr. Vajpayee, especially Rajiv, all the senior consultants from Manipal Group to come over for this important CME, which I thought would be well attended, but nevertheless. And also like to thank the senior management of Manipal Hospitals, Dr. Sonal, and others who sort of took it forward. Because initial plan, my plan was just to take it for my own Dwarka Hospital as a local presentation. When I was in the DNB assessment, I remember Dr. Yogesh was there, the DNB thesis. So I thought I'll take a presentation with them to how to write a paper and how not to make mistakes. So it grew from there, and Dr. Sakshi told me that Dr. Sonal wants it a bigger event. So we planned it that way, and I'm glad that we have very good speakers. And I hope this recording will go forward at least for the real intended audience, which is the DNB students and other things. So again, a very good evening, and I think I'll take it forward from Rajiv. Very hard-hitting talk, and how it should be. It is so practical, and we see as editors every day how these simple things are made more complex, and the paper which should be judged on its merit gets rejected on the basis of its mistakes. So warm welcome from Manipal Hospital, Dwarka. And so let me start with a very hard-hitting statement. Rejection is a norm with all good journals. Okay, and Rajiv said 5% acceptance rate for a very good journal. For this is the journal I am the editor of, Journal of Minimal Access Surgery, which is probably a very popular journal in Asia Pacific and also now across the world. But now we get roughly about 400, 500 articles a year, and roughly our acceptance rate is roughly 20 to 25%. So it's not as bad, but still there's almost an 80% rejection rate it's an index journal. So rejection is a norm. So we should all know that we are not alone in that when our manuscript gets rejected. But to understand the rejection, we should understand the peer review process of a journal. All good journals are peer reviewed, whether open access journals or whatever, they have a process which is followed. And let me start with the technical review, then the initial editorial decision by the editor, and then the peer review process comes and the final decision. So at the technical level, a lot of people make mistakes by not giving that article type or the word count, or there is an issue in plagiarism, which is a serious, obviously, misconduct. So they don't follow the guidelines. They're very easy to follow. They're given in the instruction to author for every journal, but then people make mistake. But that's not the point where it gets rejected, unless it's a plagiarism. And we send it back to the author, so that correct this, correct that, mention the article type. And then the initial decision by the editor, which obviously as editors, we want good quality articles, which makes some incremental addition to the knowledge, if not path-breaking research. And if those are not there, and by a general look at the paper, we know that it's not of that quality which matches your journal's reputation, we take a decision and reject it right then. Because we do not want to burden our reviewers with journals which are articles which are not of good quality. Anyway, it's very difficult to find good quality reviewers. So at 30 to 50% rejection occurs at this level itself. Okay. And then obviously the peer review process, where the editor depends on the reviews of the 2 or 3 reviewers to take a decision, which is, so this is the process. And when the reviewers give their comments, we either send it back for revision, which could be minor, major, rejected, or accepted. So I already talked about failing technical check initially to have a rejection. And this is basically avoidable by following the correct guidelines. And of course, plagiarism is a very serious offense, and all good journals have multiple softwares to check it. There's no way you can fool a journal. You can just put it in an Authenticate or any other. You can easily find out from where the words have been picked up exactly. So there's no way you can fool a journal editor. So don't do that. Don't do a duplicate submission, incomplete submission. So all these factors are lead to technical, the article being sent back to the authors. So as I said, Rajiv said, there's a checklist, and we all need to follow that checklist very strictly. And again, at the technical screening level, check all these, especially the case reports where people try to overshoot the word count and the number of figures and all that. So there's a checklist concept. Again, I won't talk about plagiarism. Probably it will be discussed in the panel discussion. As I said, all journals have a good software, very, very strict software, which can do a good check. And if it's caught, it's absolutely no. I mean, not only your journal article is rejected, you might probably be barred from future submissions. So the best part to avoid plagiarism is not to write from not even when you're reading the literature. Don't just put it in front of you and start writing an article. Just read it, pack it, highlight the points maybe, make notes, and then take a coffee break and write it. That's the best way. You will never be able to copy those similar words. Because if you have an open article in front of your writing, you tend to pick up the same words. Self-plagiarism is again an issue which it can happen. Now, rejection at the editor level, which I see normally, is the wrong article. It shows in the wrong journal totally. The article is not appropriate to the scope of the journal. So I'll give you some examples in the this thing. So if either it's a very specialized article, which is not good for a journal, or it's the other way around, and the work is not of interest to its readers. There's lack of any new message. Like, for example, I'll give you a lot of time people think foreign body, somewhere found is a very interesting thing. And people write it. You Google a foreign body in an abdomen, found a laparoscope, something, you'll find thousands of articles. You have to be aware that everything it may not be novel, and there's no message. And obviously then there's the quality of the articles. If it's poorly written, there's a poor flow, and you can't really make head or tail out of it. They get rejected at the editor level right away. So I'm just giving an example of how inappropriate some people choose a wrong journal. So this article, again, these are real life examples submitted to various, combination of diet and bariatric surgery helps in fatty acid profile of the liver of obese rats. So obviously, this article is good, but it's not meant for a surgical, audience where, it's too complex. Goes into physiology and biochemistry, and even the editors can't understand. So this or the reviewers can't understand. So obviously it'll get rejected right at the initial stage. This is again an article submitted to one of the very prestigious bariatric surgical journal, which So use of functional MRI to study obesity surgery news changes. I'm just blocking just to have this thing. So basically they keep on discussing the MRI modes. Functional, this MRI, that MRI, T2, T1. This is not of interest to a surgical reader. And these things happen very frequently. Now, typically, I see almost one or two articles which are not at all relevant to the journal being submitted to our journal of minimal access surgery. Or you are aiming too high. Sometimes you think your article is very good and you think, why not an annals of surgery? And some our own example where we thought will be a very good article. But then you have to see, sometimes the journals have a very high number of submissions. And although your article may be of good, it is not of that good quality. So rejection may happen and you should not feel, very distinguished. It's not bad to aim high, but sometimes if rejection happens, you should not get disappointed. So at the editorial level, what are the parameters? Poor overall quality is probably one of the simple things. You go through an article, you see overall is bad. The language is bad. The flow is bad, the study design is bad. So overall, you get an impression as an experienced person who's reading articles. There's a poor overall quality. Lack of originality. Again, we keep seeing acute cholecystitis, delayed versus early treatment results, outcomes, comparison. This is done and dusted. The systematic reviews, it's been sorted out, and people still keep doing thesis in medical college especially. They keep doing thesis on this topic and keep sending papers. So this is something which, you have to see, it's not original. It's not enough addition to knowledge, not enough advance. It may make us some point, but it's not good enough to be, published in a good journal. I think poor language and grammar makes it difficult. I mean, that's again a common thing. It's poor. It's probably such authors need to take professional help while writing a paper. There may be a good scientific study which gets rejected because there's a poor language and grammar, this thing. So you tend to reject it because you're not able to understand. So at our level, editorial level, does this manuscript contribute to existing knowledge? Are the methods employed appropriate and sound? How categories are formed? What Rajiv just discussed, about the methodology. Is writing clear and easy to comprehend, And one of the important things is the cover letter. We all think it's just a formality, but cover letter is an important thing because as a reader, we do not have time to read the whole article. So supposing the case report, you should mention the cover letter. Why is it so unique? Why are you sending this case report? Is there some new knowledge? Is it a new pathology? Is there a new surgical technique? So something, you have to mention the cover letter itself. And also, how is it contributing to the existing scientific knowledge? So you must mention the cover letter. It's just not what, a check that your word count or, the authors, but also why you are submitting this study. I won't talk about salami slicing. This happens frequently, but then, this can be a criteria for rejection. And Dr. Pooja talked about final criteria. I think most of us are aware of all this. Again, I won't go into it. This has to be followed. Poor overall quality, again, as I said, could be poor language, over-analysis of results, as Rajiv said. Do not try to, over-analyze your results. You did what you did. Say that, that's enough. Say that clearly, loud and clear. Don't over-analyze, don't over-interpret. And, and that can lead to rejection. Faulty study design. Obviously, design has to be at the onset of the study itself. Unclear research question. You include wrong database, wrong comparative groups. Again, very common. I'll show you examples from very good journals of which I've reviewed. Methodology which is not possible to be repeated. Inappropriate statistics, especially the calculation sample size where people make a lot of mistakes or intentional or unintentional. This is a study which I reviewed for obesity surgery from a huge database, 3 lakh patients. They said NAFLD does not predict worse outcomes in bariatric surgery, where we all know that it's a common sense that patient with NAFLD would have worse outcomes. A database of 3 lakh patients, the prevalence of NAFLD in this study was 5.16%, which is obviously crazily wrong because we all know NAFLD is about 70%. That means they coded the disease wrongly. They did not have the right database. Patient with NAFLD went into non-NAFLD group. And obviously then they came out with the wrong conclusion that patient with NAFLD have better outcomes. So can you believe just this is a wrong design of the study? The wrong coding led to a wrong labeling, the wrong group. And hence, even with such a large database, the paper got rejected in one go. They must have really worked hard, but obviously this is unacceptable. Again, people start with the wrong comparative group, where you should be comparing A and B, the people are comparing wrong groups, and which is again lead to wrong outcomes. Again, I'm taking an example from bariatric surgery. You should be comparing apples with apples, not with, different things. Faulty methods, as I talked about sample size. No, it could be deliberate and unintentional, especially relevant to RCTs conducted in, our thesis mostly. And surgical RCTs are really actually very poorly conducted. So we try to keep the sample size down. Either we choose the wrong primary outcome, or when we look at the literature, we look at the figure so that we take the figure not the average figure from the literature, but we take a figure which will decrease our sample size. So these things are not easily again picked up by editors. You just, especially the RCTs, if you look at the methods and you look at the literature, say, no, this is not right. There's a study saying 1% complication rate. There's a study saying 20%. Why are you taking 20%? Just to decrease your sample size. But this is again not a good practice, and again will get rejected because of faulty methods. Poor presentation of data. Your figures are poor, not labeled properly. They're missing legends. There's a repetition of data in text, and again there's a table for that. So there's a lot of material. The same thing I've said in the results in the text and then in the tables and figures. Poor coordinated discussion is obviously the Achilles heel, I would say, of a rejected paper. A lot of people just repeat the results. Discussion is not the repetition of results. They start the same thing. My study showed a 20% complication rate following this, which they've already stated. you should state why now this 20% is important and discuss it with relation to the existing literature. So his study showed 10%. So why my study is showing 20%? Give the reasons. Maybe our patients were more complex. They had more inflammatory changes or whatever, the age group. So all these reasons have to be discussed. Sometimes authors discuss only certain parts of the result. They omit totally others. It's again a very thing. So they will have taken 10 parameters in the results, discussed only 5, left the rest of 5. That means those 5 were not even discussed. You gave them in the results. And sometimes discuss something which is not there in the results. And I'll give you examples. And then obviously, problem with the discussion is it's very sketchy. So there's no flow. So you have to have a flow between the first paragraph and the second paragraph. There has to be a continuity of thought. You can't jump from idea to idea. You have to have it's like a story. I always say, I always tell my trainees, paper writing is like telling a story. It's like a conversation. So if you're able to put it in words, that's how it should go. And then you omit the limitation of study, you omit discussion of your negative results. All that is not acceptable. Too many conclusions which are not related to study results, and Rajiv has already pointed out wrong conclusions. I'll give an example of wrong conclusion. So these are the 3 examples, real life examples. In a study reporting on impact of robotics in learning run by bypass, authors mention in a cohort of 80 cases, 3 leaks, 5 bleeds, 1 mortality in 80 cases, and still say in conclusion, authors state that robotic technique is safe in their hands. The complication rate in bariatric surgery is less than 0.1%, 1 in thousands. And if you say with all these 3 leaks, 5 bleeds, 1 mortality, and then you say it's safe. So it's obviously contradictory to your results. So it's a very clear-cut thing that you are not really a pride or mind at all. 3 cases out of 30 cases bile leak using ICG technique, while 5 patients had bile leak without use of ICG. ICG is beneficial in decreasing the leaks. Does it make sense? 3 out of 5 and 5 out of something. So these are the sort of things which people put without thinking that there is somebody sensible who's reading these things. Again, this study, this is a large database outcome study. Our mortality of 0.9% is in line with global standards. While the global standard, they have already quoted the global standards of 0.1%. Now they're saying 0.9% is in line with global standards. Almost 9 times the global standards. So again, an inherent contradiction in the discussion. So again, these are not acceptable because these are important conclusions. Sometimes you have unimportant results. You do a study, 24-hour urinary volume decreases and crystalline increases marginal silver. Whether it increases or decreases is clinically irrelevant because there's no clinical impact of these studies and there's no increased stone formation. So again, these studies actually practically you might have done a good scientific thing, but from a knowledge point of view, clinical practice point of view, not really impactful. And I think the references is where you pick up the quality of the article. If the person has written references very casually, and you can make you've seen our resident sending a paper, sir, I've written the first draft of the paper. So you see the draft, the references ka aadha ye hai, kisi ka journal hai, kisi ka author hai, he's not applied his mind. If you're not thorough with the references, that means you're not thorough with the paper. This is my take on this. I always look at their references, they're not their mistakes, their omissions, the year is wrong, old references, very common practice. आप पेपर अभी 2024 में लिख रहे हैं, पिछले 5 साल की ज्यादा से ज्यादा होनी चाहिए, कोई बहुत ही अच्छा आर्टिकल है तो टेक इट, but the references are 2006, 2004, not relevant because the technology changes, the knowledge changes so fast. And providing wrong references. Again, there are softwares available to check it real time. So always check the reference style of the journal. Each journal gives you a particular way of writing. Cite recent and relevant citations, and don't try to use citations of the same journal. That's also not a very good practice. I'll just talk briefly about RCTs and case reports because these are the 2 things which come commonly. Most, as Pooja said, it's not always important to do an RCT. If you do a good quality observation study, that's a better thing than doing a poorly conducted RCT. And the problem with most surgical RCTs, at least in our country, they are extremely poor quality, based on wrong sample size, wrong presumption, wrong stats. They don't follow the CONSORT NPT guidelines, which are very easily to follow, and there's a very few 5 or 6 points on CONSORT NPT guidelines. They have a small sample size and results are practically meaningless. So People think I'm sending an RCD for publication. Oh, ये तो फट से छप जाएगा. RCD word ऐसा है जैसे कोई magic wand है. But RCDs are the thing which, as we editor know, how bad they can be. And others are case reports. Everybody sends a case report thinking, no, ये मेरा तो बिल्कुल novel case है. They don't even do a good literature search to see there are 200 cases already published. Why are you wasting your time? Even if you want to write it, send it to a journal which not an index journal at least. So either they're not novel, not rare. There's no corroboration between the images or the histopathology, or there is, they don't do a good literature search, so they don't know what is a novelty. They go on wrong on word counts and other things. And I have several examples. I have not put it there, but I have several examples. I gave you one foreign body example. If you Google foreign body and abdomen, diagnostic laparoscopy, you will find 2,000 or 5,000 maybe articles, and still people send foreign body this thing. Lipoma in intestine, laparoscopic management. It's nothing new. Whether it's a lipoma or a fibroma doesn't make a difference, unless it's extremely rare pathology. So you have to really see whether your case report is, worth publishing, and don't waste your time then, just publishing something which is very common. So my reasons are, let's say, most of our colleagues. So one is obviously an article should be simply written. It's too complicated for an average reader to comprehend. There's no point in publishing it. Faulty study design, extremely poor English and grammar, too many repetitions, deliberate omission of facts or mispresentation. People think they can fool the editors. No. I think there are very good experienced reviewers and editors who will pick it up. There's a gross mismatch between results and interpretation, poorly written discussion with inadequate review of the current literature, poor clinical relevance. I've given you some examples, or a combination of all these factors. Okay, so these are reasons for rejection. The common question whenever an article is rejected is there an editorial bias? People think, no, something is not, it doesn't like me, or it's like Westerners don't like Indians. That's a very common presumption. No, it's like white people they don't trust our data. But I don't think that's there. All editors want good quality articles. They want to increase the impact factor of the journals. They want to have good quality articles in this thing. So I think bias is almost none. I mean, within the human nature, the limits of the human this thing, I think it's almost none in a good quality journals. There may be a positive bias for a well-established researcher. That I agree. If you see an article from a person who's been writing very prolifically, well-known researcher, you tend to think, yes, it will be a good quality study. So you may have a positive bias, but I don't think because as an editor, as a person who's published so much, all of us know how difficult is it to write an article. So we do not want to discourage by just rejecting outrightly. So it has to be really bad to be rejected. And remember, editors depend on reviewers' comments in a peer-reviewed journal. So we are not putting our own, bias or decision in this thing. This is based on what reviewers have told us. And in all good journals, review process is blinded. The reviewer doesn't know who the author is. So I think important is to check formatting, do all the technical corrections, emphasize on practical applications, cite latest references, deliver a clear message. That is the bottom line. Honesty in research is, there's nothing, it has to be completely honest. There's no point in saying 500 cases if you have done 200 cases. Nobody's going to give you a Nobel Prize for that. Be honest, you've done 200 cases, write 200 cases data. Or if there's a complication, be honest, everybody has complications. So if you don't mention it, I've done 10,000 bariatric surgery, I don't have a single leak. That may be, taken with a pinch of salt. And let your manuscript be based on your scientific content and the merit of that rather than avoidable mistakes. Okay? So I think I'll just finish. Don't get disappointed. Rejection is the norm. Yes, it's frustrating. You put in so much effort, and just one liner? The editors have gone through the paper and don't find it suitable. But I think take a break. Take a break for a week or so. Don't look at that email again. Look at the paper again. Go through the comments. I think the reviewers' comments are very good. If they have been done very nice, most of the good journals have reviewers who will give you very good comments to improve the paper. They're actually made to help you. And if you go through them, you will realize, yes, my paper could have been better. go through the comments again in a very objective manner, improve your manuscript, and plan for another journal. I can tell you, my first paper got rejected thrice before it got published in a better journal. So it's always there, don't get discouraged, and it's go ahead, put your best foot forward and leave the rest to, this thing. Thank you so much for your attention. Thank you.
Thank you so much, sir. And I believe everybody would agree that it was quite a wholesome presentation with a lot of exciting details about how, what to be done when it comes to writing a paper and going forward to it. We have a panel discussion in line after this, which will be very interesting for all of us. But before that, I would like to request Dr. Sandeep to please come here for the felicitation. And I would like to request Dr. Anurag Saxena and as well as Dr. Bajpai to please come and felicitate Dr. Sandeep. Give us 5 minutes. We would be preparing the dice for the panel discussions. I request Team Ramada to please come here and prepare the section for panel discussion. Simple. Welcome back, everyone. I hope we all had a refreshing small break. And now we are heading into the most exciting part of our day, which is the panel discussion, featuring some most distinguished leaders in the medical research space of the Manipal cluster. So I would like to invite Dr. Yogesh Agarwal, Consultant General and Laparoscopic Surgery at Manipal Hospital, Ghaziabad, on the dais. Big round of applause for sir. I would like to request following Dr. Manish Kak, Consultant Gastroenterology at Manipal Hospital, Ghaziabad, to please join the dais. I request Dr. Anurag Saxena, Department of Neurosurgery at Manipal Hospital and Cluster Head of Delhi NCR, to please join the dais. Dr. Gunjan Sachdeva, Consultant DNP at Manipal Hospital, Gurugram, to please join the dais. Dr. Megha Acharya, Head of Medical Services at Manipal Hospital, Gurugram, please join the dais. Dr. Anurag Saxena, please come here and join the dais. You can make it out. It's okay. That's okay. Everybody feels good when you are appreciated.
Same attire, इसलिए maybe
Teachers are great.
Teachers are great. तो सुनने वाले को एक दूसरे पे बोल के कुछ एक दूसरे को डॉक्टर साहब ने बोला था ना ये दो बंदे आते हैं क्लास में म्यूचुअल एप्रिसिएशन
Welcome to the panel. I request the delegates to please be seated.
नो डेलीगेट्स
Forward, we have interesting topics to be discussed with today's esteemed panel. The topics are ethics in medical journal article publishing, duplicate submission, plagiarism, authorship and scientific misconduct, patient-reported experience measure, patient-reported outcome measure, research ethics, funding, and future opportunities. All the topics are very interesting if we talk about it one and again. So I would like to start my discussion with Dr. Megha. So I would like to have an insight about what challenges do researchers face when incorporating PRAM into their studies and how can journals support this inclusion? Dr. Megha.
Thank you, Ms. Sakshi. So, I would like to start with when we talk about medical research, we mostly talk about clinical outcomes, wherein we are focusing about the imaging or the lab results and whether the treatment is working or not. But when we talk about PREM or PRO and PROM, we also take into consideration the holistic picture wherein the patients are feeling this quality of life, the level of pain, how are those affected by the treatment. So when we say that the challenges that the researchers face when incorporating the data, because this is about patients' experience, there is a lot of subjectivity into it. So we need to have validated questionnaires to convert this subjectivity into something which is scientifically relevant and it is not biased. And also, it will make the interpretation of the data collected, universal. That's the main challenge that we face. And in order to overcome the challenge, the more the journals are publishing such kind of data and validating the questionnaires and giving maybe guidelines for the future researchers, so that we can make it unbiased and more scientifically and statistically relevant. That's the main challenge that we get. Thank you.
Thank you, Dr. Megha. Moving to the next question. This question is for Dr. Yogesh Agrawal. So how can the issue of ghost authorship or honorary authorship be prevented in collaborative research?
Yeah, I'll get your question again, please. The question again, please.
How can the issue of ghost authorship or honorary authorship be prevented in any kind of collaborative research?
Give me a minute to think about it. Well, ghost authorship, yes. The articles are there where the ghost authors have contributed in the research article. But how to prevent would be at the primary end of the journal itself. There should be strict parameters for them to roll in the authors, and then the criteria for authorship should be clearly defined, and their contributions, the contributions of the authors have to be clearly defined in the journal, in the covering letter itself. It should be known that these are the authors. This is the main author. This is the collaborating author. And this would cut off the authors who have not contributed, but their names are included into the authorship panel. The ethical issues also should be a part of implementing to prevent the ghost authors enrollment. And I think, yes, that's it, how the ghost authorships can be prevented in the medical research.
See, I think ghost authors, first of all, you have to see who can be an author. So somebody is there who has just collected the data over. He has done some groundwork and then he has accumulated some data. But at the other end, there's a person who has conceptualized, who has thought, who has applied mind of all the study. So now, before you go to publication, you have to keep in mind who all would be authors with what they have contributed to actually. Just because somebody is there and done a little work, he cannot be an author. So beforehand, this has to be conceptualized that who can be an author and what is the contribution. And somebody who is a primary author is somebody who has conceptualized the study, who has thought about the study, who has made a methodology. He's a primary author. Then somebody else. So this is what before study, this is to be decided now. Ghost authors, you have to see, as per the journals have to be, they have to put this review in a proper manner to see that and try to see what many journals also tell you, what is the contribution of each author you have to write. This person has done research, this person has done review, this person has this. So you have to put that.
Very right. What Dr.
Let me
Agrawal
also say, I completely agree with sir. Mostly, all the international journals which are indexed and peer reviewed, they have their set, they give the guidelines, the international guidelines of authorship, wherein before the publication, we are supposed to mention the contribution of individual person and the percentage of contribution, that who has come up with the idea, who has come up with the data collection, who is writing, or who was part of a methodology. That's how we have to make sure that the authorship is righteously given.
Thank you so much, panel. Very rightly explained.
Another type of ghost authorship.
Yes.
The person who is writing, who is coming in the picture, name is not there. Someone else is just putting his name, and this is very, very, very common to publish.
But why is he so benevolent to the people? He is doing everything, but he is not coming anywhere. He has to be a Gautam Buddha. Okay.
This is like
This is a very, very big problem with every reputed international publishers. because they are great. If someone is giving his name, he doesn't even read it. This is a big problem in everything. There comes the question of ethics of the journal, ethics of the publisher, ethics of the writer, ethics of the doctor, professor, whosoever is giving his name.
It may not be because of the generosity, but maybe because of certain other factors like hierarchy. The person may be bound to do that, and his name is not there, but instead somebody else is like Sir rightly said, the ghostwriter. So
Basically, the trend is, and just to carry on with what you were saying, that the trend is there are people who have retired from Elsevier or that from Macron and all. They're good writers, they are the British or Europeans or American people who have been helping as editorial managers. They have found this as an alternative way of making money. They say, and there have been, there are commercial organs now organized with this stuff. There's a market for it. They just send you. I have received so many requests that if you want to have, you send your papers, we'll write a book out of it. And you get very enamored because you feel that the bina mehnat kare yaar, kaam to meri sapeta. Who would do the dirty work?
So, but the work has been done by you initially, that all the papers is just going to be a conglomerate of that.
The question here is that they are doing the technical part. They use the language, they use the flow, etc., but they are using the work that you have done, highlighting it. We can even talk about this aspect. Is it good or bad? Are we using as secretaries? They are like secretaries who are helping us writing a book. But if you take a leaf from what you were mentioning, the book was written by those people, and it's your name. And here is where you have to decide yes or no. So the thing is that it becomes a fine line then, because it's all your work. If they have elaborated it into now, there is ChatGPT, AIML. Very easy for your work to be blown into any shape and form. This should also be discussed here today, because this is going to open up a Pandora's box.
So actually,
Today the journals do not. Only 20% of AIML content is allowed in a publication, and that's not called plagiarism. So this quantum might change either way. Grammatic mistakes, English literature writing component is allowed more and more because you subject it to certain kind of radar, and it comes back to you and they said that the language is perfect. They don't mind that because it's a perfect language then. So these are the things which are coming up now. We should sow a seed for that also.
so this is about the individual.
I have gone through all these things. I know this part of the publication probably a bit more than you people, because my books, I have been a writer for almost more than 2 decades. And all my, fortunately, the books are from very highly reputed international publishers. They are, when I am talking with their good editors, this is their genuine concern. Sir, we are receiving manuscripts day in, day out, but we do not know whether we are writers. When some professors like Sir or they are representing, they are quite okay. But if an unknown person who has never written even a single article in a single index journal is coming forward with a book,
And it raises the question.
this question that we are requiring. That is this a genuine, or is that someone else has written for them as what Sir has said? So this is a big issue, both within our field as well as other fields also.
So this is like
Non-fiction.
it's a gray area basically. This is where the ethical of an individual comes in place. That is everywhere, as you have said. It is in each of the every area or every field it is there. But the crux of it is that we should, at my level, be able to give the credit where it is due. If somebody has helped me in grammatical corrections of the manuscript, it should be mentioned somewhere. They may not be given the authorship, but they may be mentioned.
There are two sections, authorship and
Acknowledgement, yes. Yes, so it should be acknowledged.
There is significant contribution.
Yes.
It's very interesting the way the conversation and the debate is never ending about this panel discussion.
Messages.
Moving forward to the next question. My question is addressed to Dr. Anurag Saxena. What role do funding sources play in influencing the research that gets published? And how can journals remain impartial despite the potential biases?
Right. It's very obvious that all clinical researches and trials require money, they require funding from one source or the other. There's quite a research in the resource intensive job to do that. And most of the industrial driven or pharma driven fundings, we know that if you go through the literature and you go through it, they have more positive outcomes as compared to a neutral or an institution funded setup. In those cases where the funding is coming from a particular organization which has a conflict of interest or has a valid business idea to fund that particular research, those things can, I mean, there are guidelines for authors. There are guidelines, and I think ICMG guidelines are also there. So you have to mention who is funding it. You have to mention the funding number. You have to mention the exact role, what the funding authority is supposed to do, whether the author has any restrictions in publishing the data, other things, because there have been cases there where pharma companies or any company who has been funding the particular research have sued the authors for publishing a side effect of a drug. This has been there. This has been well documented. So there are stricter guidelines, but how good they are followed, if that can be implemented, then probably we can come up with probably a neutral source. And the second way of preventing is if we can get an institutionalized funding, which is neutral, and there should not be any proxies from the pharma companies. There can be third party involved in funding, which might later on turn to be proxies of the pharma company. If that can be avoided, there can be some business models the funding models where more government initiatives or more neutral bodies like UGC, something like this, can come up with funding for research institutes and give more money. That can give at least a neutral idea, and the funding bias which is there for the writers and for the authors should be avoided.
I think ICMR has something like ICMR, which has to fund. Somebody has to be there to fund all these studies. So if you see, I am a member of American College of Gastroenterology. So every year they come out with this funding. They come out with this thing. Notice that anybody wants research funding, please apply. And this is not anything pharma-based or anything. So you have to put your research protocol. You send something. Send your this thing synopsis, and you will get the funding. If they feel this is appropriate, something normal. So beyond pharma, also there are organizations who can fund your project. Your project has to be a good one, a strong project. Funding is available, but this funding, pharma funding is going to be a problem. It's very difficult to come out of this because this is going to stay there, and it is going to be a positive trial. 80-90% times it will be a positive trial. This is what is important.
Another important, a very interesting thing which I was reading few days back was conflict of interest committees or conflict of interest teams. Committees which are neutral, and then they keep a track of funding of a particular study and what exactly the financial incentives are to authors, or is there a funding bias, and this completely neutral body who is just overlooking the funding part, who is the funder, who is the author, are there any financial interests, other things also. And this is a new concept coming up. I was just reading few articles and I found that. So a conflict of interest committee, especially in private institutes or pharma funded or industry funded articles.
So as you very rightly said, Dr. Karp, that there should be a pool of money because money is required for research. This pool should draw money from different companies, irrespective whether it is CSR or a pharma company. But then the research should not be that contributor specific. It's a pool which becomes neutral the moment the money goes in. That funding from the must be getting money from sources.
Yeah.
Pharma may be one of them. But at the time of granting grant to a particular applicant, it doesn't mean that pharma company is there in the picture. Money becomes neutral there. So that kind of thing should be encouraged. Whereas if you know there are pharma companies who have asked for this research, make sure that it has a bias. It won't survive. There will be very few people who would be so neutral. There will be honest people who want to know the data and then work upon it.
Can I put a question to you? We have luminaries from the government sector who are present in this hall. They have given wonderful talks earlier. I just want to know, you have been active in research your entire careers. You have produced excellent results. But what was the amount of percentage of funding you got from the government sector to encourage your work vis-a-vis the private sector?
The private
Sector funding, the share of the funds.
I'll tell you a few things. Good research does not always require funding to prepare a good idea. Now, but when it comes to laboratory supports, the reagents are very expensive. And for collecting data properly, for the reagents to be done by the laboratory, need manpower. That needs funding. Therefore, I would say that except for the very initial part when the funding was always there actually, but the amount of funding was very small, but it expanded into a full center by the ICMR because we were doing all over the place. So without funding, you can't do large data, indisputable large data. You need collection, that titration, calibration, etc., laboratory. As a surgeon, I know, and I'm not ashamed of saying this, I wanted to find an answer. It required some tests, which was done in laboratory in a medical department, corresponding department collaborator. When I went there, he said, we need 2 lakh rupees for this work. How can a faculty get 2 lakh rupees for a research idea which he wants to use patient samples to do it? That was the time when taking sample was not an ethical dilemma. You could have taken and then tell the parents. Then I realized that I can't do these things. Then I went to ICMR for funding. So funding is extremely integral to good work. And as I said, I want to repeat that.
Totally a waste trying to say that it's easier for the government to get funding, not the private to get funding.
I think so.
See, the problem is, one second. The problem is that you are doing a randomized control trial of a drug A versus drug B. Now, both A and B drugs have to be without any label, without any mark. So they are going to go to a patient, a nurse has to come, deliver, other person has to see, then you have to make readings. This is manpower, that manpower needs salary, these drugs need this, all this needs quotage. So much money, of course, is involved for doing a trial. So somewhere somebody has to fund. Because nobody funds, so the pharma industry is there to fund.
So believe me, I mean, if you look at good drug trials, they're very well conducted. They're extremely well conducted according to the checklist. They're so strict about each and everything. That I think it's an overstatement. I think it's a myth that I think a lot of results are management. It's not.
No, it's actually.
It's not.
See, I'll tell you,
The results are double blinded, the analysis is different, and they're conducted.
I'll tell you, from my experience from Tata Memorial, I was in Tata Memorial, Mumbai. There are so many RCTs going on. In my presence also, I could see there were two containers. Nobody knew anything about that. Principal investigator PI was somewhere in his room. He didn't know who is getting what. Nurse didn't know what she's doing. This A is given to this patient, B is given to this patient. They're all similar. Containers, boxes, vials, they're all similar. No difference. No difference. And nobody knows who's receiving what and nobody knows who's giving what.
What you just said, my schoolmate, classmate, very good friend of mine, is in an language and he is almost leading a team that funds the research. So one day, just you, yes, I just asked him, how fine, the right person fund. There is one. There are who is the author, who is the researcher. He just goes to the plan, goes to the idea, and if the team considers it what funding, they will fund it.
But that funding is through the government.
Through the government.
Yeah.
Through the government.
So then there's a neutral body, right?
What I believe should be done in our case. There is no doubt from parts of big companies. They are all channeling that money into their sectors, but not using them. So now is the time that the government should look up and build up a fund. Say I say one of the apex body. Why not we open Infosys? Why don't we open CCS? The people need money. Let them fund the all products. Why only technological advancement? Why only AI? Why only iPhone? Why not them? Until unless these private companies will not get fund. And if you do not get fund, you will not get research. Now, why China has gone so far in their research field? One, they interested in basic research. We are not into basic. So this is one way, because from my experience in government sector, last few years, especially after COVID, I've seen the amount of money coming from these private companies into government sector. This is just mind blowing. Ever in my career, I've seen so much of fund coming into it. I am from municipal corporation. From municipal corporation, which is not a research organization, the amount of money coming to municipal corporation to build up the healthcare infrastructure, that is mind blowing. So this is something that ICMR should look into. Not only pharma companies, not only XYZ, it is every top 500 companies of Nifty. All top 500 companies of Nifty, their CSR, the percentage of it should go for health research. That is probably one of the efforts by which we can do.
So the question here is that money should be moved into a neutral fund. Not sponsor specific research. So that is just like American investment policy. Example, they can't give better example. Pull it up, then let people come and a few companies like Tata, I was going to say, you name these companies, Infosys, they're going to name them. They do research, as Sandeep mentioned just now. They do real research. They are honest. They want to really know the result. But then it can't be said about the very rich company in America, in Bombay. And once upon a time, to visit a laboratory, you were told that you can't enter the lab. So you know what they are trying to hide. You know how such things happen.
Actually, I just want to say something about your perspective. So I said that when we are in a private institution, there is a lot of where we get the fund and why the government is doing more. So I want to come back to the first slide Dr. Rajiv showed that why we do research. So mostly researchers are done for philanthropy. Now we are talking about. So the most research we are doing it for philanthropy reasons. Because with the research, you get the results which are going to affect the masses. Now the organization to find what is the intent. If the private organization is the intent is profit, they cannot just give money for the research. And there are many of the funding government agencies, there are so many agencies which are also funding the research in the private institution as well. It's just about the idea. Like we submit a book, there is a private sector organization cannot submit an idea.
I've been to committees where the fund it's been very. Of course, when you're in a bigger teaching institutions, there are support departments. The project is much more comprehensive. I'll give an example. A project will come from the private sector. One investigation calls for covering one investigation. Otherwise, not contributing anything to the knowledge of the in that field. Just to get one reagent for that particular, they will apply. Obviously, that doesn't work. The project actually really, government really spends its money, and there's a very good committee which goes through each and every project. They call the researcher to present before the committee. Once it's shortlisted. It's not that it's a bias. It's just about the merit of it. And
So you're talking about like one single institutional study. For what about the multi-centric studies? So if it involves too many centers,
yeah.
how to allocate the fund? Who will be the funding authority and other things becomes, for example, yeah.
All the PI present, and if it's a good project, it's done. I mean, problem is very difficult to get from the surgical project to surgical.
फार्मा वाले तो मल्टी कर लेते पूरा इंडिया मल्टी सेंट्रिक ऑलरेडी दे मैनेज
Exactly.
So I think this discussion was very interesting, and there are different answers to different questions. Going to the last question for the panel discussion, the question is addressed to Dr. Chandran. What mechanism can we use to ensure that vulnerable populations are represented in the medical research communities? That's the last question. So I think vulnerability, first of all, let's just
understand what is vulnerability. Vulnerable, the word is right from the Latin word to wound, means that those people who are, facing more challenges to be harmed in the research. For example, the children, the elderly, the pregnant women, lactating women, and apart from that, people who have cognitive impairment, people with mental disabilities, and other ethnic groups, people who are terminally ill. So all these people, and the first and the foremost thing starts with the informed consent, the written, voluntary, informed consent, usually, which has three essential components. First, that the relevant information should be provided by the researcher. The second, that it should be legibly, it should be comprehended easily in a simple language. And third, that it should be voluntary. Now, especially with certain groups who are more vulnerable, let me just point out a few of them. For example, children. So wherever we have the basic outline for a consent, that yes, it should be stated it's a research. Second, that what is the method and what is the purpose of undertaking the research. Then you have what is the time duration which is expected to carry out the research, and then the benefit. What will be the outcome of the study and how will it benefit the individual and the community? And whether there is going to be any adverse effects or any inconveniences to be faced by the participants in the research, the little expenses or the payments which may be given to the participants, and any time whether the participants by their own will can be moved out. If they do not want to undertake the entire research, they can give the consent to any time leave that research. So coming to specific groups, for example, children, let's say, I'll start with that because where do we have this study where children have to be enrolled? So I think there are certain criteria for that and mechanisms to ensure that safety of the vulnerable group that you said. The children means what? But individual who is less than 18 years of age. So obviously when they're very young, we know that they do not have that cognitive ability and the legal guardian, that is a parent or the legally authorized representative has to give a consent, And as they grow up, they have that cognitive ability, but they still lack that legal capacity to give their own consent. So wherever a study involves only children, where a particular disease or a disorder is found only in children, there the study has to be undertaken. Am I correct, sir? Or if the same disorder is found in adults and in children, but there are issues which are starkly different between the two groups. So there it is to be undertaken. So any of these criteria. And I think moving on to another vulnerable group where we have the terminally ill patients, because there the research is undertaken because there is no other way. This is the only ray of hope that maybe those terminally ill patients can receive by way of research. So there it is especially important to make them understand the complexity and why this research is being taken. So again, a consent is, I think, one of the most important factors which will play, and it has to be properly taken. So it has to be ensured that these are, more systematically taken and in a better way as compared to the non-vulnerable population. There are other things also where the ethnics, minority communities, and people who are, but that's a small subset of the people who are vulnerable. So yeah, I would like to, maybe somebody can address this.
I think vulnerable population, because it's a very specific and high risk, usually either an elderly or a pregnant or a child. We have to be very careful and very meticulous why we are actually doing this study. So I think this is very important in this vulnerable group, that why this study is being done, that has to be very clear-cut and meticulous. Because you are using a group of population which is at very high risk. And again, of course, consent here is said. And safety is to be kept in mind, that we are not compromising with safety of a person by doing a study. So I think the rest all is whatever I said, that is correct.
I think ma'am has very explained in detail about the vulnerable group. And with this, do we have any more questions to the panel?
Sorry. So basically, for how do we ensure that they are protected is like the consent and the way it was taken has to be elaboratively described. The journal has to make sure that the question ki why the population was included as in is the same population is going to be benefited by the study that is being taken and the methodology the consent is obtained. These two things have to be very elaborated and transparently, mentioned at the time of submitting the public paper.
So there are certain cultural issues also when we take a consent, especially in our country, where we take it for a pregnant woman or a lactating woman. The women will want to talk about this aspect with their family. That also has to be considered. And there are certain things that the safety has to be ensured. And then if suppose a woman of a reproductive age group becomes pregnant during that point, she shouldn't be taken out of that research. Again, the importance of consent comes here into play. So the little issues with, I think, subsets of the group where vulnerability is a concern or is an issue.
So I think with this, we turn the panel to an end and to a very interesting discussion. Now, I would like to request Dr. Yogesh Agarwal to please come forward, and I would like to request Dr. Meenu Bajpai, Dr. Sandeep Agarwal sir, Dr. Tapas Kole sir, please come for the felicitation ceremony.
Board picture. Like.
I think we get up.
Yeah.
Yes.
I think we get up so that they can take us progress.
I would like to have a picture with the whole panel and everybody together.
Thank you so much. Thank you.
Request Dr. Manish Kant. Dr. Anurag Saxena. Dr. Gunjan Sachdeva. The most important person of the Manipal Hospital Gurugram, of the Medical Services Department, Dr. Megha.
Old colleague of mine from AIMS. Young, old.
And last but not the least, I would want a group picture with the panel and everybody around here, and I would request everybody to felicitate me for that.
Yes.
मैडम सारे सीनियर लोग बैठ जाइए, बैठो, खड़े हो जाते हैं पीछे, आप लोग बैठ जाइए सब। That will look very nice.
Yeah. With the
अबे आप लोग सीनियर लोग
नहीं मैं
तो सीनियर है।
we'll keep it on the way.
Can you shift that up there?
Yes. So standing there, everybody will not come. So we
That is good. The young people will sit. And the senior people will stand.
The youngest will sit first. मैं वहाँ पे सारे लोग बैठे।
सिक्सटी कर रहे हैं बैठने के लिए तो बैठ कम
I think come.
सर प्लीज आइए अच्छा अच्छा अपना अपना लेके ऐसे नहीं खुल के ऐसे
ऐसे छिप जाएंगे सब, हम छिप जाएंगे, फिर हम छिप जाएंगे।
ऐसे कर लेते हैं ना?
ऐसे करें, that's a good idea.
Yeah. But he's taller now. ऐसा दिख रहा है क्यों?
अगर
I'm the one person
Yeah.
whose picture does not have a memento and I do not like it.
हाँ
Don't feel it. I have zero.
नहीं नहीं सबसे ज्यादा अपने स्टेशन
सारे question.
contribution yes sir appreciation is more important.
Are we good?
Yes, सब दिख रहे हैं और सबके मोमेंटोस भी दिख रहे हैं. It's fine.
Thank you.
Okay, thank you. Before we disperse, Dr. Yogesh wanted to say a few words. Had requested so
Yes.
Yeah,
yes.
few more.
it is actually my pleasure. And well, very nostalgic day for me. When I was driving down from my part of the country, Delhi, I was skeptical. Yeah, ये लंबा रास्ता नहीं. Research methodology. I studied this subject when I was doing my MBA in FMS and found it very, very dry. And practically, in terms of clinical research, my exposure has been small. Like Dr. Vajpayee said in his, I think, once in a lifetime, I heard that talk of his, where he said there are three categories of clinicians: one who collects data, one who does research, and the bridge between. So I was actually the person on the side of collecting data with just workhorses doing our work the entire life. Not much of research, etc. But yes, that statement of his made a lot of impact on me, and the quality of the interactions which we have had, I think it is absolute amazing. One of the finest meetings I have attended after long. This concept of
Research connect.
the connect, it was not a research, it was hard connect. And Professor Sandeep, I always admired, always in my last 25, 30 years, I have known him 25 years. He's been an amazing human being. And thoroughly enjoyed, really thoroughly enjoyed whatever he spoke from the heart. And I am floored. Thank you so much, Leena ma'am, for organizing this, Sakshi taking it forward and catching all of us. And since morning, I had a busy day in the OT, but yes, the heart was jana hai, jana hai, jana hai. But I think it is worth every penny I spent today to come and attend this meeting. God bless you all with many more such connects, and really would love to participate more proactively in future meetings. Thank you so much.
Let's connect.
Let's connect.
I am lost in presence of you all because I do not belong to any academic category, frankly. From Municipal Corporation of Delhi, I started my job in 1996, and from then on, as Sir has said, 3 branches. I was in the collecting data side, but practically I was not collecting anything. Now, while in service, after 5 years, I realized that I have nothing to do, how to spend time. So that is when that thought of writing something came into my mind. And I realized that it is also a type of research. I have written more than 20 books and more than almost 25 articles. Though I will not say they are pure research, but what I have realized is that to read or to write one page, you have to read at least 500 pages. So when throughout my life I have written almost 10 lakh words, it's not a small thing.
after writing, just I was telling them, after writing 4 lakh words, Oxford University said it is too big. Now remove more than half of it, and they put it into roughly around 1 lakh 50,000 words. So when you read or write 1 lakh words, you have to read almost 10 lakh words. So that is also a type of research. Those who are not purely into clinical one, and especially when COVID came, I was requested by Taylor and Francis to please write a book on COVID for international audience with everything. I said everything is there in Google, but still they said no. In Google, whatever is there today will disappear tomorrow. But we want something which will last. And then at that time, I read about Spanish while writing about COVID. Then I realized the importance of why writing, why one should write, why one should study, and why one should study and put it in writing. Because in Spanish time, there were hardly any good books which I could come across to write while writing for COVID. So this is very important that what I write today is not only for today's generation, it is for our future generation as well.
Generations to come.
Yes. Another thing I am telling you, when Oxford University published my book, I was just something beyond my time, frankly speaking. A municipal corporation, medical officer, or a specialist who has no standing in his own country, how can Oxford University publish his book? But when the book came out, they told me, so this book paper is treated with chemicals against the termites. I said, why? They told me that your book will be there in the library stand, and if it is not mishandled, it will be there for 200 years. So the thought process that goes behind there and what you are writing is so important. Because when I started reading about medical negligence, I got only one book in Delhi Law Faculty. I am not a lawyer, of course. In Delhi Law Faculty, that was a book by Kian Wright. And that book was published way back. It was dusty, but you will not even touch it. It was so horribly kept, full of dirt and everything. I started my journey from that, Delhi Law Faculty Library. I studied for 8 years on medical negligence law only because I did not have anybody to teach me. I self-studied. And then in 2 years, it took me writing, and Oxford University helped me to compile that in the form of a book. I am truly indebted to them, but I think that is also a type of research.
Oh, yes.
That is also a type of research.
I'll just take one word by thanking all of you. There's something that Dr. Kole said which really, struck a chord. And when he talked about COVID, when they say that kuch to acha hua hai COVID se, well, what happened is we stopped our, not I would say stop, but the momentum of deliveries, the check-meals, the stop. When I was just approached to start the Department of Academics here in Manipal. And we realized that we had a lot of free time on our hands, although we were still, OBG was still going very strong during COVID. But I remember I got such a lot of support from everyone because everyone started putting their thought process. And that's how academics and research came to Manipal, Dwarka. And it's really very, very nice that, after so many, years, we have come today. Of course, we have a long, long way to go. And the journal is there with you, sir. And now I remember what I think Dr. Sandeep and Dr. Rajiv mentioned about 95% rejection and 5% acceptance. हम लोगों का ऐसा है कि 95% acceptance. So it's such a baby step we've managed to take, and it's all because of COVID. So I think a lot of sometimes in adversity, some good outcomes happen, and we've got to pick up those good, opportunities that come our way. And
this book of COVID was also an invitation from Taylor and Francis. They gave me a call. Sir, you write on COVID. I said, why? There are so many good authors, so many people all around the world are working on COVID. I am nobody. But said, no, you have to write. And in 1 month time, they took it.
And probably I am the first physician of India whose book is published in Western world. The second edition is not even in India, it is outside world.
First book on anti-termite paper.
No, that is Oxford. At least I don't know.
Thank you, everybody, and I hope that with this research connect, we will connect again at a bigger, better, with more fuller platform. And I would like to thank each and every one of you with joint hands because all are seniors to me, and you have helped me through this journey of planning this whole thing.
Thank you.
Thank you so much. Yes.
Okay, good chair.